of your mic. Somehow your
Okay.
slide got cut off, so I see the only left upper corner of the screen. Okay, a little bit more center would be better. Can you give us a minute? Okay, good. Now you got it. Okay, let's go ahead.
So can you hear me very well? Because right now I'm at the hospital. I think the internet is not stable here.
Oh, is anybody from Myanmar and Mongolia having trouble listening? Dr. Hang from Cambodia, please send us a chat writing. So how you guys connections and also visual. Any problem?
Okay, so maybe I should start now. So good morning, everyone. Good morning again, Dr. Huang and all the other professor at Yonsei Children Hospital and all the other doctor and professor from Mongolia, Myanmar, and all my colleagues in Cambodia also. So we are very happy to share you this second monthly international conference. So today we have two topics. One is about ECG discussions, and then another one is EGM discussion by Dr. Manuel. So maybe we can start by ECG presentation. So we can spend around 15 to 20 minutes about this ECG, and then we will proceed to the EGM. So this is my case. A 35 years old male patients that come to the emergency department. Then he was transferred directly to our cardiology department because of the sudden onset of palpitations. And this time he experienced the first episode of his life about the palpitation, and he also feels a little bit dizziness, but without any syncope. So he doesn't have any family history of sudden cardiac death, and this is his ECG. So could you please have the comments or drop your comments or discussion in the chat, or you can open the mute and discuss here also, and then we can listen to our senior doctor. It looked like severe complex tachycardia with heart rate very high, about 274 beats per minute. So what do you think? Is it an SVT bit aberrancy or is a VT? Can anyone give us answer, please? You can drop your comment in the chat so we can see your comments about the ECG.
My name is Taeyeon Hwang from Yonsei University, and it looks like white curve tachycardia with more than 250 beats per minute, very fast white curve tachycardia, and the V1 shows the RBB morphology, and lead 1 negative and lead AVF is positive, so it might be ventricular tachycardia originating from the left anterior fascicle or the papillary muscle we see, I think, but How about Professor Tae-Hoon Kim?
Thank you so much for your answer.
How about lead 2? There was some notes on the T waves, maybe in the middle of the reading strip. We discussed about the possibility of the AV dissociation using lead 2.
And can you blow up that ECG lead to bottom tracing? Increase your gain. Let's focus a little bigger. Can you make your slide bigger a little bit?
It's bigger right now?
Yes, that's good. Okay, leave it like that.
Could you follow some a little bit more later strip? I can detect some notes on the T waves. Yes. Maybe 2 weeks later. However, in the week 2, there is also we can find some notches on V2.
V2. Here also.
V2. Right. I'll bet SVT.
Okay, thank you so much. So is there any participant who think that this
Hang a
ECG?
second. Hang.
Yes, Dr.
Let other people see the ECG first. And then
Yes.
some
Okay.
people, some people is a little bit slower than us. So you got plenty of time to make them think. And then we can discuss. Okay?
Okay.
Good.
So maybe first SVT or VT, and then we can discuss.
Now what's the purpose you gave us patient history? You gave us,
Maybe
yeah, you
at first I want to show the ECG only, but
okay.
I
So
think
that understood. But you told us the patient is 35 years old.
yeah,
He had a new onset of a palpitation and rapid heart rate palpitation tachycardia. And then obviously he was near syncopal. And then this explained because of rate, right?
yes,
And then let's describe your ECG first for the people to analyze a little bit better. So this is a wide complex tachycardia,
yeah,
right bundle branch morphology. If you blow up the V1, go up there, blow up the V1, a little bit bigger. V1, yeah, that one. Yes. This is a typical right bundle or atypical right bundle.
look like a typical right bundle because R is smaller than R prime.
Right. But then if you notice that almost R, right?
Yeah,
And then V2, you have a notching, which is the first notching R smaller than second complex R. And then V3, they get reversed, right?
yeah,
And then V6, you have a deep S wave, V6, Victor 6, yes. And then how wide that it is, that S wave. Is it clearly more than 100 millisecond, right?
Look, 3 small square, so it's around 120 milliseconds.
Yes. So is it more than 100, right?
Yeah.
That's why I'm telling you all this. So when you see this description I gave you, that would be in the Brugada classification of VT, would be VT. Okay? Now, is there any relationship with Dr. Kim just described the P waves, okay, you can see time to time, with the QRS complex? Look at the V1, for example. Your V1, 1, 2, 3, 4. Yeah, Victor 1, or first on the top, yes. If you follow, there's a small notching variation just before the onset of your QRS. Yeah, that guy. And the next one, next complex, that changed a little bit. And next one, change again, right?
Yes.
So that suggests that there's something going on there. And also you can see that similar phenomenon in V2 and at the end of a QRS complex. You can see there's no notching, and then third bit has a notching. Notching get bigger, 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 and then disappear again. So there is no clear-cut P or H activity, assuming that's H activity, association with the QRS complex, even though rate is very fast. But then if that is a P wave, you have also tachycardia on atrium, correct?
Yeah, it could be.
Could
But
be.
the rate is also fast.
Yeah, I mean, if that's your PP interval that you're measuring, patient in atrial tachycardia or some sort of atrial tachyarrhythmia. So your ventricular rate is a 274 beat per minute. Is the atrial tachycardia that go that fast is what? What do you call?
Atrial flutter with one
Atrial
conduction.
flutter. Yes. Oh, rapid atrial tachycardia can do that. So you have a description so far we made is that patient has a wider right bundle branch morphology, QRS complex, more favorable for ventricular tachycardia. And HLP wave, you got a fast tachycardia rate similar 270 plus, could be atrial flutter, and could be or atrial tachycardia. So, but appears to be there's no correlation between atrial activity as far as we can say with the QRS complex. What that means that the differential diagnosis would be what? One is atrial flutter with wanton conduction, possible, but can explain QRS complex. Second is what? Atrial flutter and the ventricle is two different rhythms, so you got double tachycardia going on. That's also possible here. Okay?
Yes.
So if you go down, take a look at go to the lead one. Let's look at the lead one, not the V1, lead one, label it. So if this is a ventricular tachycardia, where's it coming from?
Look like anterolateral walls of the LV.
Okay, so it's a high, right?
Yeah, high.
Can this be some sort of a left ventricular high septal tachycardia?
I don't think it's subtle because lead one is negative predominantly, so it could come from the lateral wall, not subtle wall. Right.
You think so? Okay. And then next question for you is: this can be any figure equal to pathway, pre-excitation, AVRT, conduction, aberrancy. Because you got tall RA V1, and then you got lead one. You have you just described to us is more anterolateral. So then anterolateral, certainly you could have a pathway, right?
Yeah.
But what is against it? All the left lateral pathway R waves are concordant, right? Have you seen an
Yes.
X-ray pathway discordant? No, but that's very unlikely. So trying to look at where the source of tachycardia, and then you can put a differential diagnosis, and then you can try to match whether the pattern is typically you would see in the high left lateral pathway. No, this is not a pattern of precordial left lateral pathway. So that's out of picture. Okay? So you're left to
Okay.
what? Double tachycardia, possibly atrial fibrillation, atrial tachycardia, and a ventricular tachycardia originating from the left ventricle, as you described, a high anterolateral. Any other difference of diagnosis we should make? And aberrancy, could you explain this? Not based on the QRS complex morphology we see. Any additional comment, Hang? Anyone from the audience or anybody else, please give us your input, what I just described to you. So how many of you guys are favored for BT? How many of you prefer SBT, like Dr. Hang is asking you?
So I saw in the chat, Dr. Ted, I'm sorry if I pronounce your name wrong, Dr. Ted Levi.
Yeah, sorry.
Please comment that it's a VT. So can you open your and give us some comment, please? Could you, Dr. Ted?
Hello, can you hear me?
Yeah,
Yes, we are
thank you.
well hearing.
I'm seeing this tachycardia as the white complex tachycardia with the right bundle branch block morphology and with the some AV dissociation I can see. That's why I'm commenting this as a VT.
How about atrium? You think there's a tachycardia going on?
Yes, as you mentioned, I can see some atrial activity. So maybe this might be my differential is a SVT with some aberrancy. Yes.
Okay, thank you so
Cannot
much.
exclude SVT with aberrancy. Yes.
But you think more likely it's a VT, right?
Yes. Yes.
Okay, thank you so much. So is there any other comment, please? And then we can proceed to discuss the whole case because I think we have some time limited right now.
Sure. Go ahead.
Okay, so Dr. Ted, could you give me some idea about how to manage these patients? I can say that this patient BP is around 100 to 110 systolic. I think it's more stable, but he has symptom of shock because cold extremity, and we can like the peripherals pulse is still good, but he has cold extremity. So what is your management? Could you give us some idea about the management for these patients?
Yes, if he present with this to us at the ED, we would, I think, we would defibrillate him to cardiovert to the sinus rhythm. We would try to give the DC shock. Yes, defibrillation.
Yeah, that is a good idea. And thank you so much. Is there any other comments? So I could give you my management plan for this patient. So I saw this patient around 1 month ago when I was on duty at the hospital. So he come to the ED and then transfer direct to us. So the BP is stable, but he has symptom of cold extremity. So at first, I also hesitate like you, Dr. Ted, to do the defibrillation directly or give medications. But at the end, I decided to give him verapamil IV because the BP is still good. So we inject verapamil 5 milligram because I think also like you, it's the VT and most likely from young male patients that doesn't have any history of cardiac disease or syncope or family history of sudden cardiac death. So it could be a VT, idiopathic VT from anterior fascicle. So I give him verapamil 5 mg for 5 minutes, but the rate is still the same and it doesn't change. It just lower a little bit, like 270 down to 260, but it's still the same. So BP is still stable, the patient is still conscious. So I wait another 5 minutes and give him another 5 mg of verapamil, but still no response. So I decide to do defibrillations like DC cardioversions. And then this is the ECG in sinus rhythm after cardioversions. So we can see that it's the sinus rhythm without pre-excitations, and also some repolarization abnormality at the inferolateral wall of the LV at V5, V6, and lead 2, lead 3 at ABF. And after that, the patients, after return of consciousness, because we give a sedations, patient doesn't feel any chest pain. He feel better, and the BP is going up to 130, and he feel very well without any symptom after the cardioversions. We did echo on site after cardioversions, and the ejection fraction is normal without any without any wall abnormality, and the heart is normal, no dilated, just a structurally normal heart. So we still doubt about this ECG, but because it's not respond to verapamil and we do cardioversions. So could you give us some comment, please, Dr. Huang?
Now, why you think that this is the anterior fascicle VT?
At first,
Tell me what is your description of typically anterior fascicular VT looks like?
yeah, it's first it's RBBB morphology with voice complex tachycardia, and then
Right. Hang a second. What is the idiopathic VT to be fascicular VT QRS duration? First poll. What's the QRS duration?
Yeah, normally it's less than 150.
No, 115.
150.
120 is the average. Okay? Even though your QRS complex initial activation is relatively sharp, but if you look at the lead 1, it's pretty wide.
Yeah.
And then also lead 3 and the AVF. So this is a bipolar ECG leads. You're talking wide complex tachycardia. That alone is very suspicious, your diagnosis. The reason I say that is that usually anterior fascicular idiopathic VT, they originate fairly proximal to the lap bundle. As soon as the anterior fascicle branches up, tended to come very proximal segment of anterior fascicle. So that's why people been describing, they are able to ablate as soon as you enter aorta and then curve up the catheter, you'll be right there. And even there's a case where they ablate from the coronary cuspid. Okay? So higher the conduction originating VTs tended to be narrow as possible QRS complex. This does not fit to your anterior fascicle VT criteria. Okay? Let me explain why your verapamil did not work. So you probably want to relook at the case and take a look at it. Let me know. Okay?
Okay.
There's many leads that feature of anterior fascicular origin idiopathic VT is this not this wide. They tend to be very narrow. Okay?
Okay.
Okay. Second thing is that you have no notching any of the QRS complex in inferior lead, all pure. That is also very unusual. even though we call anterior, it's not actually anterior. It's almost middle heart, because left bundle comes up and then it branches out to the anterior and posterior fascicle. Posterior fascicle comes to lower, so then you can see RS pattern, very small R peak, R wave in the lead 1 to 3 in AVF, but dominantly Q RS. But this one has no Q wave anywhere. All R or QS. So you need to look at the EKG classification a little bit and then go review that. Okay?
Okay.
I'm just a little bit troubled about this EKG pattern called interfascicular idiopathic BT. Is possible papillary muscle BT? Could be. That depends on where the papillary muscle is, because they can vary depending on the location of anterior papillary muscle. As you know, papillary muscle can vary widely in patient to patient. So something that you can think about it. Okay?
Okay.
All right.
So thank you so much for the comments.
Yeah, so if you see patients that you're describing almost the pre-shock picture of a patient extremely cold and all that. Now, this 12 ECG, you thought that this was pre-excited or not?
No, it's not
Okay.
precise.
I just want to make sure. But if you can look at this patient has almost like left ventricular hypertrophy pattern, LVH pattern ECG. Could be a young gentleman with a very variant, but then QRS is not normal. Am I right? In sinus rhythm? What's the
Yeah.
rate of QRS? Wider than normal. You don't expect to see 30-year-old male patient with this wide QRS complex. I think more than 80 milliseconds, this one. I'm looking at it.
Yes. So
he has some, can you see that 2-3 AVF has a downslope of a J wave, J point? 2-3 AVF. Your S segment down, even lead 1. What's the explanation of that? And then P1, you have a segment elevation, right? Yeah, that's you're up the baseline. You don't expect to see normal ECG, normal guy. So you have evidence here that the patient has activation, QRS activity abnormal. Perhaps even repolarization mechanism also deranged, abnormal. That would favor for some sort of cardiomyopathy. Okay?
Okay.
So just go back and take a look at that carefully, even the patient does not have any family history. But I think this EKG is a sign of rhythm, but not normal. Now I'd be more trouble with this. So I would not be surprised he can present with the VT. Okay? In other words, patient of a depolarization, repolarization abnormality, sinus rhythm ECG. Why the QRS complex, S segment depression, and T wave discordance. So it is something that we should be thinking. Okay?
Okay.
Any other comment?
So we also discussed about that with the interventional doctor because the patient is young, no risk factor, no chest pain, so we did not do any angiography. And then the next day, I'm sorry, I lost the ECG. The next day, the repolarization is returned to normal, but the QS pattern is remain the same.
Okay, so I think could it be what we call sustained VT cardiac memory that lasts some time, day or two. Also, you had the cardio version, but the QS duration shouldn't change that much. So you need to, you need to follow up this patient. Okay.
I saw him like last Wednesday.
Mm.
I give him verapamil 120. He feel that it's better, but sometimes he also experience palpitation for short durations, but it's not the same like the one he experienced when he was in the ED.
Okay. Why not beta blocker? Let me ask you that question.
First, because I still think that it's an anterior fascicle, so that's why I give him verapamil.
But then you did not have any clinical response, not even slowing VT.
Yeah.
So what's the justification to give verapamil? Because if you have fascicular VT, VT may not terminate, but they sometimes tend to slow down. Okay, that's also a possible response. So if you review your record of tracings during the tachycardia after the verapamil, if there's any heart rate variation slowing, okay, even few 10 beat, 5 beat cycle lengths, that can be very useful. And so Professor Mogami always discuss about that in the lecture. And it's not just him. We all believe that verapamil response can be partial.
I can say that I observed him during we gave him verapamil. The first injections, the heart rate slow just 10 beat, and then return to 270 again. And the second injection is no response at all.
You know, verapamil response is a little bit different than adenosine because it's just a long-acting calcium channel blocker. So if you gave a second dose of verapamil, you should slow further down if it is a fascicular VT. In other words, dose-dependent phenomenon is very common. And also, once you slow down, they stay down. They don't speed up like what you're describing to us. Okay? So I don't know whether it's in any fascicular VT verapamil response before. And they tended to have a slowing down and then slow down for a few hours sometimes. Okay?
Okay, thank you so much.
Thank you for your presentation. Now, who's going to present the EGM?
So maybe I can give the slides to Manuel to present it. Good morning, Dr. Manuel.
Good morning.
Good morning.
Mm.
How are you?
Good. Good. How about you?
I'm doing great.
So I will share the screen right now. Can you see the case?
Yeah.
Yes.
Let me know.
Yeah, we can see very well. How about Mongolia and Myanmar? Can you see all screen well?
Yes, yes, we can see.
Thank you.
Everyone can hear me clearly?
Yes, yes.
Okay, let's go, Manu.
Yep. Good morning, everybody. Good morning, Dr. Wang and friend from Cambodia, Mongolia, and Myanmar. So I am Dr. Pishmanir from Khmer Soviet Friendship Hospital. I will present, I think it is an interesting case for me and one of challenging case. So this was a case a few months ago. So the patient is 33-year-old female. She presented with a recurrent palpitation for almost 10 years, but she was documented with PSVT, and cardiologists prescribed beta blocker, flecainide, and refractory to antiarrhythmic drug for the last 3 months. And she was referred to us for further management. She has no cardiovascular factors and no family history of sudden cardiac death. So on the examination, the transthoracic echo shows completely normal cardiac chamber sizes, normal LV diastole and systolic function, and chest X-ray show no significant finding. So this is the first documented ECG from a cardiologist. So this is a narrow QS complex tachycardia with a heart rate around 160 beats per minute. And I think I can see clearly when the patient came to visit me with inverted P wave morphology in the lead 2, lead 3, and AVF, and also kind of positive in lead 1. So I think this patient has a long RP prime SVT. If you have any other comment, I think you can comment during this presentation.
So you describe a patient has a narrow-complex tachycardia, Manuel.
Yes.
QRS is normal,
Mhm.
and you have a retrograde. You thinking there's a retrograde P wave negativity in 2, 3 in AVF.
Yes.
P1 is a positive.
Yeah.
So that means coming from where?
So I have a differential diagnosis.
No, it's you're talking about that. So P2, P3, P4, P5, 6, P wave will help you.
Yes.
Lateral precordial.
Yeah, precordial lead.
Okay.
Yeah.
Initial vectors that P wave and lateral precordial what? They're negative.
Mhm.
Second portion is looks like maybe
Oh,
isoelectric or positive.
yes.
Okay.
Yeah.
So that means is without differential diagnosis, where this atrial tachycardia coming from? If you assume this atrial tachycardia, where do you think is it coming from?
So I think for me, it is coming from the low portions, and the P waves looks a little bit narrow for me, and the V1 is positive, coming from posterior and lower and more subtle for me. So yeah, so
How about
this,
P3, P4, P5, 6 is of initial negativity. That help you?
I think V1 is
Positive, right?
yeah, mostly helpful to me.
But a V2 you can see already notching it down and up, right?
Yeah,
And so
by
you can see,
face.
yeah, initial portion of P waves. And so you could argue whether this P wave is coming from the left side posterior. If it was the right side posterior, lateral precordial lead should be positive, right?
Yeah.
But this is not a positive, definitely. So you could argue, if you want to look at that a little more specific for focus who wants to look at the EKG, you can argue that this could be some sort of atrial activation, inferior, anterior, and left to the right. How's that? That's fair?
Yeah.
Okay. Now, if you look at the lead V1, there's any change in relationship between P and QRS complex? It doesn't. Very fixed, right?
Yeah.
What does that mean to you?
Narrower.
Yeah, it's not a diagnostic, but a favor for one versus another. How about when your automatic tachycardia, the relationship can vary a little bit, okay?
Yeah.
But when you look at the RP relationship, it's stable until proven otherwise, it's a reentry. Okay?
Yeah.
Okay, very good. Okay, let's go.
So this is another documented during tachycardia. I think it's similar morphology and rate to the previous one. So she has many episodes of SVT and admitted. So similar rate for me, and also the morphology also similar to the previous one. But interestingly, some really worry about a little bit a slur in the V5, V6, suggesting maybe vegetation, but I'm not sure about this.
So if you assuming your observation is correct, you're thinking there may be some antegrade conducting pathway. Is that what you're thinking? That's why you're
Just
telling us that?
possibility.
Possibility,
Yeah,
right?
just a possibility.
Okay, then if that's a possibility, then what's the differential diagnosis here now? We are here to exercise you guys' brain, okay? So you got narrow QRS complex tachycardia, some lead suggestion, perhaps there is pre-excitation during the tachycardia. So differential diagnosis is what?
I think it's AT with accessory pathway as a bystander,
Okay, that's one. Second
flutter,
one. What is the other one? Perhaps to do two different pathway, but first pathway has to be very long retrograde conducting pathway. Third, what? Slow AVNRT with a bystander pathway. So you got three possibility here. Any other possibility? So you mentioned atrial tachycardia or atrial flutter, some sort of atrial activity that has a bystander WPW pre-excitation intermittently. That may explain why your QRS becomes slurred. Second, two pathway with a retrograde conducting pathway, very slow conducting pathway. Number three is what? We discussed that is a AVNRT bystander pathway. Okay? All right. That's good enough, Manuel. Now,
Yeah.
what is the other possibility of that you have your P wave influencing your QRS onset? Can P wave change a little bit QRS morphology because of fusion phenomenon? Yes, you can. That's another possibility here. Okay?
Yeah.
Because it's a long RP tachycardia. Okay? Let's go ahead.
So I think it's a long RP tachycardia with the differential diagnosis of atrial tachycardia, atypical AV nodal reentry, or PJRT. And another documented ECG, I think is very interesting. This
Okay?
goes. So also she's documented in from time to time SVT with a regular pattern, and I think this occurring with AV blocks, and I think the AV block in this setting can rule out pathway participating in this SVT. And as Dr. Wang mentioned in the early comments, I think we can still have diagnosis of atrial tachycardia originated from low posterior subtoral portion, or still atypical AV nodal reentrant with a lower common pathway block. So that patient, I didn't see that patient during tachycardia, but these are all documented from other center, and they gave adenosine, and it reported it responsive to adenosine.
So hang on a second there.
Yeah.
Your EKG morphology of P wave, they are all P wave the same or they're different? So
I
that's
think-
what you need to see first. Or
I
P
think
same P?
I think the same. I
Okay.
think, yes, very clear
Mhm.
just after the block, and
Sure.
the
Sure.
other is fusion with the terminal T wave, I think.
Okay. So your mechanism block is what? Hmm?
These can be autonomic change or
So what do you call this block here? What I'm asking you. Is not this is a mobile long atypical mobile block?
I believe so, kind of,
Because it's a group beating, number one.
yes, group beating.
Your atrial tachycardia is regular. Okay?
Yeah.
The HR rate. Then you have looks like a bunch of 5-bit blocks, 4-bit blocks is vary. And then if you look carefully, P2R segments slightly prolong until it blocks. The
Blanket.
pattern keep repeating again, right?
Yeah.
This is what we call
Blanket batch.
atypical Wenkiba.
Okay.
Why is it typical? There is no fix the coupling last conducted bit to the block bit. If you look carefully, they vary. Okay? This maybe has to be because your HR rate, tachycardia rate, may not be same. If you look at that example of that block to P wave to the subsequent conducted one, to the right next one, get shorter.
Narrow, yeah.
Yes. So when your source of HR activity varies, they can exhibit a typical type of Wenkiba. Okay? So they don't follow absolute rule of a Morpheus 1 block, Dr. Wenkiba described. So we call atypical Morpheus 1 block. I agree with it. It's a very interesting ECG. So thank you for bringing ECG for teach us about the atypical Wenkiba.
Yeah.
Okay. Anything else? Any other comment? You still think there's a delta wave?
No.
Okay.
So next slide is no more sinus rhythm.
Okay.
Yes, you don't see any suspicion of precipitation and normal QS duration for that age, normal echo. So the patient was brought to, this is chest X-ray, small heart for young lady.
I'm glad you brought your chest X-ray. Okay.
Yeah. So EP study. So because of my lab was in renovation, so I cannot have enough X-ray image for them. Sorry about that. So this
Okay.
scenario you be placed because of primarily I believe the patient is more likely with AT. So I use a duodeca catheter to cover from CS to the tricuspid region, annulus region, and one in the RV and another in the his region. So during the catheter placement, you can see that there is a lot of inducible clinical tachycardia. There's even just put duodeca catheter. So this is inducible tachycardia. This is the initial basic sinus cycle length. Things are normal AH, HV, and QS duration during study. So I'm sorry, I cannot see this. Just wait. Sorry then. So are we pacing from apical pacing 600 milliseconds? Since can see no VA conduction in this patient. As you can see the sinus beat and the V pacing is not retrogradely conduct to the A. So we proceed to the A study. So we study on atrial stimulus in this patient from 600, 500, and going down, showing decremental property in the AH delay. You can see that. So this is the cycle length with S1, S2, strand 50. We can induce the tachycardia. So what we can see is the atrial activity is earliest at the duodeca 5-6. Duodeca 5-6 is around the posterior subtor, around the CS os. So we proceed the procedure for this. I cannot see the sorry. Okay, nice. So this is the earliest tachycardia cycle length 350, earliest retrograde at the 5-6, and you can see kind of far field atrial activity from 5-6 even earliest, comparing the surface P wave. So there is a lot of tachycardia cycle length variation during initiation. Every time the tachycardia initiation, we can see a lot of wobbling phenomenon in this patient. So I also take this as an example of interval change prediction. So in this patient, you can see the AA interval predict the HA interval. 320 millisecond predict HA interval around 320 in the subsequent bit. So my diagnosis become a little bit more clearer that it is unlikely atypical AVNRT because of this feature. So I try to do ventricular overdrive pacing, but it is untrainable. Can you comment on this?
What do you think? Is it trained or not? When you think that that was entrainment,
I
you
don't
think
think not able to entrain.
no, because you just did overdrive suppression diet, right?
Yes.
Because
Yes.
if you look at the right atrial activation, completely changed. And then was the return cycle was okay?
So
Did you imagine return cycle from after entrainment?
yeah, I
Okay.
did.
You did.
So so I also wonder if it is in train kind of suppression. So the recording in 5-6, the VA interval is distinct. It's a little bit different.
Yes.
Yeah.
And then what is it? What else is different there? That channel.
And also the atrial activation on the first return cycle is different comparing
Right.
to during pace.
It is good to see your atrial activity far away from your pacing site. So your pacing from ventricle, so it doesn't matter. But more critical importance here is that I want you to look at the EGM of 5-6 during the pacing. Did it change? That's the earliest activation you had. That's my question to you.
Mm-hmm.
You got clearly V preceding that noisy thing, okay?
Mm-hmm.
And then post pacing also you have a long fragment signal in the 5-6. Do you think they'll change or not? That would be most important question regarding whether you're entrained or not. In other words, did you think you captured the focus, whatever this tachycardia, whatever we are talking? You did or did not?
I don't think
Yeah, you did not.
Yeah.
Tachycardia is still going.
Yeah, still going.
My eye here, I look at the fragment signal. Yeah, it's absolutely no chance of anything happening because your local V, far field V, relation to the segment change a little bit. Okay?
Yeah.
Plus EGM characteristic is the same.
Yeah.
Okay. Fair enough.
Next slide. So because I tried do repacing, and I think it's not untrainable. I try the atrial of the right pacing because we still not sure what is a typical AVNRT or AT. So I try atrial overdrive pacing, and so the return, so the capture beat of atrial overdrive pacing VA pace interval is 183 milliseconds, and the VA interval during tachycardia is 200 milliseconds. So there's a lot of changing of the VA interval, suggesting the lack of VA linking in this patient.
Okay.
Yeah. And also during study, I also do atrial pacing at the high right atrium at the same particular cycle length, 330 milliseconds. And there's a small there's more different of AH interval during sinus rhythm pacing and during tachycardia, spontaneous tachycardia cycle lengths. So one suggestion is the smaller AH interval can rule out AV nodal reentry in this possibility patient.
Okay, let's go.
So
You don't think it's AVNRT? Okay.
yeah,
Okay. Go
so
ahead.
this is summarize finding.
Mm-hmm.
So this is the inducible clinical narrow complete tachycardia. Tachycardia continue despite AV blocks, so we can exclude AVRT. And I do atrial drive pacing, no VA linking, difference is 20 milliseconds. So I think this feature is unfavorable of atypical AVNRT, and also multiple time of tachycardia cycling fluctuation. And we can see the AA really predict the HA interval, also suggesting of atrial tachycardia, and early SA activation at the right posterior subtle region. So I conclude that this patient is an AT originated from right posterior subtle region.
There is one thing before you go there, okay?
Yeah.
Go back to your slide. Right here. You still think that your posterior subtle early? Look at the first panel of EGM and during the tachycardia. You got a clearly his bundle in his distal. So
Yes.
you have a proximal his, positive, negative in distal. And then your CS also, you don't see much EGM there, but it looks
Yeah.
like there's some noise like before.
Mm-hmm.
So seems to be your septal P wave also fairly early.
Yes.
So is that already favorable not being AVNRT, especially atypical one? Because atypical AVNRT, your CS has to be much earlier than his A.
Yes.
This tracing that you have, not suggestive of that. So instead of you doing all this important maneuver you done really well, sometimes looking at the intracardiac EGM carefully,
Yes.
you can tell right up front, this does not look like a AVNRT because the intracardiac activation patterns doesn't match.
Yeah.
Second conclusion is what? If your septal A, posterior septal activation is almost same time, especially your proximal, your earliest CS is a far field, 5, 6, 7, 8, 9, 10, you have almost no EGM. But I think 5, 6, you have a far field EGM. 3, 4, you have a near field, which is later, which is the left side appears to be. And would be start thinking, your focus may not be right at the posterior septal, somewhere a little bit away where the impulse invading both catheter, his and the coronary sinus catheter, almost same time. That makes sense?
Yeah.
You know?
Yeah.
Okay. Go ahead.
Summarize finding that.
Yeah, you got it. So go ahead.
So I proceed to mapping these 80 patients,
Mhm.
and I use a focused lasso catheter to map in the right side first, and I found at the posteroceptor is an early signal in the posteroceptor region from the lasso 11, 12, but I think I missed at that time, but I believe this may be kind of PAC that was induced by catheter.
Well, go back there, Manuel. You do the lasso 11 and 12, 9,
Yes.
10. You got double potential there,
Double potential.
right?
Yeah.
Which is almost same time as the duodeca 3-4.
Mhm.
You agree?
Yeah.
So therefore, one catheter in the left side, another is in the right side, you said, right?
Yeah.
I don't know how close your septum it is, but certainly CS56 appears to be the earliest in my eye. Yeah, that guy.
Yeah.
Okay, but again, that's a far field signal.
Yeah.
You cannot trust the activation time in far field signals. You don't know where they're coming from. Okay.
Okay. So I think this patient really tend to have AV block. So every time I even put his catheter or I'm during the mapping with lasso, a lot of induced SIBOR or AV block during tachycardia. So this
You
is
clinically never seen this though, right?
yeah.
You never seen clinically this such a long AV block on patient.
Yeah.
Okay.
So we can see clear P-wave onset.
Okay.
Yeah. So we map. I use irrigated ablation catheter flexibility
Mhm.
to map, and I think at that time a little bit of frustration. So I think this is a good signal, pre-systolic or pre-PVAL around 35 milliseconds. So I decided to try a burn there as a first application, and there was no effect on the tachycardia. I think the try around 20 seconds for this application, but no effect. So
Why think that there's no effect, Manu?
I think the stability is good.
No, it's not.
No,
For
but
you to
contact.
listen, yeah,
Yes,
it's not a contact.
yeah.
For you to apply energy to the target area, first of all, you need to have a local activation early as possible. Your catheter, look at the proximal signal versus distal. What do you see? Proximally clearly see a local activation
Yes.
later than distal, but distal does not have any local time. It's
Yeah.
all far field.
Yeah.
You don't want to apply energy in the far field area. As I said, you have no idea where this impulse is coming from.
Yeah.
So goal is, if you find such an early activation time, make that as an ablation index. Is that, in other words, that is being earliest site, your near field signal need to be that much early for you to deliver successful ablation. That's what that means.
Yeah.
So I want everybody to understand that very clearly. For you to ablate, you do need a near field signal earlier than that far field signal. That's your goal. Okay? So far field signal does not mean bad signal. It can give you idea how much of my blood signal need to be earlier in order to be successful. Okay?
Yeah. Thank you.
Okay, very good.
Yeah.
Go ahead.
So no effect on this side.
Uh-huh.
I try also maybe 2 times at this side, around 10 seconds or 20 seconds. So I think, maybe I should map to the left side to see what happened at the left subtor side if it is earlier. So I did subtor puncture like you seen in the first slide.
Sure.
So I try to map left side. I think it's not really much earlier. I think at the left side and kind of far field signal on the lasso 11, 12 and pretty much similar earlier comparing to the right side. And I do a map by ablation catheter, and I think this is even maybe better in the right side. So I try one burn in the left side, and there's no effect. At that time, the FC mapper thought, oh, it's a good signal. I think yes, agreed. So I tried one burn, and there's no effect in this patient. So I since after that I review the EGM a bit, and I think oh this should be right sides, not left sided, because at the time we updated at the left side, it is not pretty much earlier than right side. So I put back all the catheter to map to the right side meticulously. So this is the left side ablation. And there's no effect. So I map to right posterior subtor region very carefully, and this is the success side that I did ablation. As you can see, this is very much earlier with, I think it's a fractionated far field and followed by a local AA potential with a big V. I think this is a good contact and pretty much earlier, around 58 milliseconds, comparing to the P-wave and also much earlier than the local atrial activation in the duodeca polar catheter. So I tried with 35 watt 45-degree irrigated ablation catheter, and within this is the position of catheter ablation in aerial view and in aerial view. So within 5 seconds or 6 seconds, the tachycardia is terminated at this point, and you can see pretty stable in proximal and distal ablation signal at this, but a little bit change. I think it's maybe because of abrupt change or tachycardia termination. So I continue to burn, maybe. So at this site, I not imagine that this is a risk of block. So I was happy that tachycardia is terminated. So there was a VA block during application at that success site. So I missed a few bits. So there was a VA block. I think this is the right inferior extensions retrograde block. And then I stopped burning. And later on, I give maybe 2 burn more at that side because of I use a 3D map, and I did with atrial pacing to evaluate the AH interval during ablation. So I'm not sure, maybe this is kind of a part of slow pathway part or whatever that can cause a retrograde block. As you can see. So I stop, I off, I missed a few bits of block. I think if I continue, maybe something worse happen. So after ablations, I did a study again with and without isoprel, and there's no inducible tachycardia until 200 millisecond or atrial pacing. This is picture 3D map at the success site. Thank you.
Okay, what are the things that you tell me could do better next time when you see same patient, Manuel? I think that's a whole key point we're trying to teach people.
Yes. So I think we should understand clearly about the EGM analysis, especially I think like the first ablation, it is not a good signal like this. Even you can see a earlier signal and even earlier than PVL onset, but it is not good context. Also, it is indicative of far field, not a local. So I think there's no effect even you try to burn like 10 times ablation, and you can cause arrhythmia in the future in this patient. And I think I'm not sure when to map at the left side. Also, if Dr. Wang and other college friends can comment whether you need to check on the left side in this patient or not.
So let's assume that you had some difficulty of mapping, identifying the focus of tachycardia. Okay? Let's assume pulsoreceptor region. What can you do to avoid the complication, do better job? What is missing here? You don't have any anatomic information in this patient, do you? You have no idea how the coronary sinus looks. You have no idea how the MCV looks like this patient. And you don't have any septal junction area. So what we should do next time?
I think venogram.
Yes,
Right atrium.
exactly right.
Yes.
You need to do the venogram.
Yeah.
Okay?
Yeah.
And then you had a transient long heart block. You had a slide there. Where that thing coming from? Have any idea? This block here.
Means
Is there some mechanical business going on, or this is just truly her AV node is sick like this?
I think some mechanical. It is blocked at the nodal.
Yes, but I agree with you. But the question is, what is the mechanism? But you should know whether his sponsor is tickling, any other catheter mechanically hitting this patient, or there's anything else happening.
It's mechanical.
Okay, listen.
Yeah.
You had this patient chest X-ray, right?
Yes.
Why did I say I'm happy that you showed the chest X-ray to this patient? What is the use of a chest X-ray? You just for look at the heart size? Or the additional use as an electrophysiologist looking at the heart?
I think also the orientation of the heart, the shape.
Okay, what else?
Also
keep going.
important.
It
And
is important for you to look at the size of a heart, selection of your catheter, which one you're going to use. Assuming that you have a heart even smaller than this, would you put a dodeca catheter here?
I don't do.
So what's the risk of putting a large catheter on the right atrium curling? Your dodeca catheter come how?
Yeah.
Come from septum first, you're curling anterolaterally, trying to put into the coronary sinus, right? Then what happened to your right atrium? They stretch. You don't think a dodeca catheter just fit into the right atrium. No. They are relatively stiffer catheter in small heart. depending on the where the shaft, ascending portion of a duodenal catheter shaft it is, can be very in the septum, can be posterior, can be a little bit more between. You're gonna affect your alveolar conduction. Okay? During the manipulation, you can tickle the septum, cause heart block. So in baby children, you should never ever use such a catheter. You always use a separate catheter, softer. So you don't need a high lateral information. You already EKG tell you that the tachycardia coming from the posterior septal area. You already diagnosed a well-made diagnosis. Matter of fact, that's very good. I would use the just quadripolar HRA, his bundle, RV catheter, and the decapolar coronary sinus direct intubation. Okay?
Yeah.
And then go back to take a look at your slide of a catheter initial transeptal picture you show us. Okay, right here, take a look at it. If you look at this catheter, how they are curved. Look at the ascending shaft where it is. Pretty close to his bundle catheter. Do you see that?
Yeah.
Catheter coming from the IVC, going to the septum, but unfortunately going to the his bundle area. And then you stretch that thing to the lateral wall. What it's gonna do with the time pass by? It's gonna keep hitting the septum, especially during the tachycardia. So you need to think about those things when you do procedure, especially young normal heart. Okay?
Yeah.
Okay. Second important point is what? Your duodenal catheter cannot be placed most of the time, I have to say, but a lot of skilled people can put it in. Beyond the Bisson valve, they usually get stuck into that valve. And then you end up having even more tension because you're trying to push that into the more force CS. So therefore, you have a two hinge point with a very stiff catheter. Okay? But my problem is that you're trying to map the posterior septum, and your duodenal catheter cannot be maneuvered. Whether you can map roof of CS, floor of the CS, lateral, posterior, so on. You cannot move because otherwise you got a whole thing on the move. Correct?
Correct.
So it's not very, practical standpoint view is not useful catheter. So it is something that you need to think.
Yes.
What type of catheter I'm going to use for this patient? Not every patient is the same. Therefore, you need to evaluate the chest X-ray. Plan ahead. I'm going to use a 2 quad, a 3 quad, a duodeca, whatever. At least you thought about it. It's very good. But are you doing without thinking? No. So we need to make a habit of it. Okay?
Yeah.
All right. Go ahead. And then you'll notice that your duodeca recording from flow of the CS catheter. They're awesome. That's why you don't have any EGM. 9, 10, 7, 8. And then the earliest 8, you see 5, 6, but that even also a little far field. Only distal 2 pair is in your field. Okay?
Yes.
You can analyze activation time with that kind of EGM. It's very difficult. So I think that was one of your first problem. Okay, let's go. Next. I'll make a comment. I don't want you to hear this as a criticism, okay? I'm trying to teach you.
Thank you.
Okay,
Yes.
keep going down. Keep going down. Okay, you did a nice, beautiful maneuver. You proved this is a focal tachycardia. I agree with you. Okay, keep going. Okay, wonderful. Okay. So if you see that tracing right there and during the, no, just before that, you had you had the 2 panel tachycardia and another one that you did the maneuvering. Keep going down, I think. One more, keep going. Yeah, that's one. If you saw here this point, you are not very happy with where the earliest activation site is, especially in the left side of the picture. What could be done? This is a time when you want to know anatomy. Okay? What is the danger of your ablating posterior septum? Do you know? Why we always worry about the posterior septum?
Since also can cause AV block, collateral
block.
damage,
Second one is what?
collateral damage to
Collateral damage,
artery,
including
yes, artery node.
yes.
Yes.
And there is a small artery that always exists in most of patients who has a dominant right coronary artery system. We call posterolateral branch that crossed MCV right behind it.
Yeah.
A lot of time when you do ablating CS os inside O MCB area, you can potentially block that up. Unfortunately, many patients don't have any symptoms. That does not mean it's a good thing. So this point, if I were you, knowing that this ectopic atrial tachycardia could be inside the CS, could be left side, and so on, I could have done venogram coronary sinus system, proximal area, using a SR1 sheet, and then I could have done right coronary or left coronary angiography to find out which is the dominant system for
Okay.
safety of the patient. Imagine you have a huge posterolateral branch in 30-year-old lady, have a MI. I'm not sure which one is worse, MI or tachycardia ablation. So always think about what you can do in your country. You can do angiogram, you can do all this thing, right? You don't use a 3D to do this stuff, but then you do have a capable with the angiogram in every patient.
Yeah.
So think to remember, when you're playing around, when you're ablating around the coronary sinus or proximal CS, cardiac catheterization, right coronary angiography or left, and then venogram. For pathway, for tachycardia, whatever. It's going to be very useful for you. Okay?
Okay.
All right. Go ahead and next. Let's go down. Keep going. Okay. Keep going. Yes, you. And then you had the ablation. Okay. So a lot, ablation EGMs, and then you did a picture. Show us a picture of your ablation site. Can you show that? Where you think that the left side is clearly posterior septum, right? Left septum. And then you came out to the right. Next picture. Find
Yes.
a nice potential.
Mm-hmm.
Okay. And then where did you ablate? You had a picture too, right there.
This time. Yeah.
Yeah. Where do you think that this is? Inside the CS or outside the CS?
I think it's outside.
How do you know it's outside? Look at the EGM. Go back and look at the EGM. Ablation distal. Can you have such a big V outside the CS? Have you seen it before? CS proximal has what? Dominant,
Okay.
big A, small V.
Yeah, small.
You're already moving away from manuals, right?
Yeah.
Your EGM telling me otherwise. You're pretty close to ventricle, this thing.
Yeah.
How big that V is, you're showing, point out to us. So if you done angiogram, I almost bet money on it. This is also the MCV. Okay. Some patients, MCV is surprisingly close to CS os. So I think you just had a better stability of catheter because you're in MCV os, and then pointing down, and then look at your LAO view. You're right at the CS plane. Look at that. You see? Yes. So if he was atrialized there, you got to be more posterior to that, or maybe even higher. No, you're not. You're at the annulus, probably inside the CS, right at us. You're pointing at the MCV. That's what you are. This is an MCV os atrial tachycardia. That's what you're looking at. That's why if you look at the EGM, go take a look. Your ablation is site signal. Very nice, sharp potential, much bigger than previous ablation site. And then you got long fragment signal. And then what is that second potential? Q. Point out ablation signal. Sharp potential positive. First one is a positive. Go to the left. Yeah, that one. Why I'm telling you all this? For you to ablate a focal tachycardia, your ablation distal has to be R, cannot be Q. That what does R mean to you? Your impulse coming directly at your catheter. Okay? And then what does that negative mean? Going away. But how come so bigger than that small potential? That is a left atrial activation. Make sense now? So you got MCV musculature activate so early, exit out, invade the coronary sinus muscle, and you have a far field left atrial signal. If you draw the line of that thing, I bet it's almost same as a CS 5, 6, 7, 8. All right?
Yeah.
Make sense now?
Yes.
Yes. So next time, try not to be in a hurry to burn, Manuel. Enjoy your EGM. because you need to conform first your catheter stability, as I told you before, impedance stability, and then fluoroscope view, whether your ablation catheter need to be synchronized with your CS catheter. Then you're in contact. So good signal is yes. Next step, impedance stability, EGM stability, fluoroscopic synchronization of catheter motion with the CS. Any place around the mitral annulus, you have to keep that in mind. Right free wall, left free wall pathway does not matter. You have to be in contact. You have to be in synchronization. Otherwise, your catheter is going to move around. It's not going to create a good lesion. Okay?
Okay.
Great. It is a great case. We
Thank
appreciate you presenting nice case for us. Anybody has any question, comment, please? Nobody? Is it time to ask now if you have a question? Okay, there is some questions, looks like. Oh, that's a different, I think that's from previous chat, not this one. Manu, can you do me a favor?
Yes.
Send the case to PPT file for me.
Mm-hmm.
I will
Sure.
make all this comment written down, and then I send it back to you. You can share with other people.
Yeah. Sure.
Okay?
Thanks. Yes.
Great. So that
So-
way everybody can review and learn.
Again, I have a question.
Yes, please.
So what you think the mechanism of these tachycardias is triggered automaticity?
It is automaticity. You go back
Automatic.
to look at the ablation. Answer is there. Ablation response. Very first burn. Okay? You had the successful ablation, right?
Yeah.
So where's the RF on? You did not record that.
This one,
Yeah, you have a good signal. You burned it. Where's the RF
Yes.
on signal? No, that's ablation signal. I'm talking RF on.
Ah,
As a
oh,
synergist.
during okay. I didn't put it in.
Okay, so please put that on your file. Important.
Yeah, okay.
What typically happening that the radiofrequency ablation response also additional data to confirm mechanism of tachycardia.
Mhm.
If you have a reentrant tachycardia, they depend on how quickly you're burning that whatever that critical isthmus, your tachycardia may slow down, terminate. Okay, but reentrant tachycardia, you have a PAC, anything like that termination, that's not a termination. That's basically PAC blocking the reentry. All right. So that predicts the successful, unsuccessful EGM and ablation. Second, if this is automaticity, you should see some acceleration at the burning end because they have automaticity triggered by thermal injury. Most of our atrial tachycardia. If you see that, then you would be favoring for the atrial tachycardia. Okay. Now, if you have tachycardia that terminates abruptly without changing rate, that was most like a trigger mechanism is probably the involving on it. But here you have some cyclings wobbling here, I can see a little bit. But unfortunately, you cut up very first bit, which must be longer, get a little bit shorter, and get longer again, terminate. So measure that out on your caliper to see what I'm telling you, what it is. Okay?
Okay.
Great. You add on that slide into your file, and I will make a comment.
So if it is automaticity,
Yeah,
is it responsive to adenosine because this patient responsive to adenosine?
that's correct. Yes. Automatic trigger would not respond.
Yeah.
Re-entry would not respond. If this is a local re-entry and atrial tachycardia.
Yes.
And story also tell you though, patient was refractory what?
Anterior.
Flecainide, beta blocker.
Yeah.
You use that, this patient.
Mm.
So flecainide and the beta blockade response is in terms of a mechanism standpoint of view, re-entry would be much more responsive, better than trigger, and then focal tachycardia would be more refractory. Okay? Even though flecainide has a calcium channel blockade effect, and that's what we use for CPVT patients, but not this kind of automaticity. Okay?
Yeah.
Yeah, affected at the adenosine positivity, probably you may be dealing with the automatic cells somewhere. Anything else, Manil?
No, for me.
If you have any other question, you can add in your email. Then I try to respond to you. Here, what happened, by the way? What think is happening here?
Yeah. So during burn, VA block.
But one bit conduction here. Do you see that AV conduction? Yeah, that bit. That's what I got shorter. That's conducted. That tell you what?
Fast pathway conduction.
Yes, is it heart block? Or you're still burning it because you're creating heart block? What do you think?
Yeah,
Burning into the CS os and the posterior receptor area. What do you have over there? Also, you have sometime AV nodal artery there,
okay.
right? You need to know that. Second, what? Ganglion plexus. But then you don't have a bradycardia here. Again, you cut up my first bit there. So whether there's a significant fluctuation of heart rate during the burn, that may not be truly blocked. Could be see a bigger response. Okay. So that's why some people do autonomic modulation in coronary sinus area when you're burning that thing. So you should know looking at the tracings. Okay.
Okay.
I agree with you. You did the right thing. Stop burning. Yes, true. And then if you want to burn again, pace the atrium and burn. Okay.
Yeah, I guess atrium. Yeah.
Yes.
Okay. Thank you.
Thank you. So next conference, who's going to present?
Things maybe Mongolia.
Myanmar or Mongolia?
I'm not sure. Maybe it depends. Professor Kim. He will arrange.
Okay. Anyway, I don't want to make any comment in 3D activation yet. I know you got 3D map there, but I have a comment, but I won't because you are not there yet. So we will discuss about this first, the basic mechanisms, because this is the purpose of conference of teaching. And then we get to the 3D mapping comments and other things as the things we get more advanced. Okay.
Okay.
And the other people who attended the conference today, any question, you're too shy to tell us in public, send me an email. Once I get the file from Manil, I will overview and then make a comment, and I'll try to answer your question best I can. Again,
Next
right.
country is Mongolia.
Mongolia. Okay.
Yeah.
Last thing that we want to know from all your focus, give us a feedback, whether this type of conference is helpful for you or not, either how we can improve this conference. Give a suggestion, because we are early stage, we certainly can accommodate many good comments, bad comment as well. Is not a bad comment. I don't take it personally anyway. So please give us a feedback. That would be essentially important since we are putting a lot of effort for you, your standpoint, dedicating time early Saturday morning. And I want to make sure it's worthwhile for everybody. Okay?
Yes.
Great. Thank you for everybody attending, and I'll see you next month.
Thank you so much, and see you.
You're welcome. It's a pleasure. And then also send us email.
We see you. Yeah. Bye-bye.
Bye-bye, Manil. Good job.
Yeah.
많이 늘었네.